Hello, everyone, and welcome back to Let's Talk Patient Blood Management. Thanks for joining us again. It's May already. Can you believe it?
I
This year
cannot.
is just flying by. And I
Uh,
think that May is generally thought of as Bloodless Medicine Month. Is that correct?
it is.
So today's episode, I think we're going to talk a little bit about bloodless medicine and its benefits.
Let's do it.
So we are so delighted to have with us Bradford Ray. It's always a pleasure to speak with Bradford Ray. Bradford is a perfusionist. He's a graduate of Ole Miss Mississippi College of Perfusion. He's also a founding member of the Society for Advancement of Patient Blood Management, which is outstanding. He's a co-author of the mass casualty event occurring in El Paso, Texas on August 3rd, 2019. And he's a director of research in trauma and emergency medicine. He has several journal articles written on new technology in determining hemostasis and the author of the Anemia Power Plan for transfusion reduction. He's participated in research for the Mayo Clinic during the COVID crisis, testing patients for the benefits of convalescent plasma. He serves as educator for the residency program for pathology for Texas Tech University in El Paso, Texas, and advanced practice for transfusion reduction. And he's participated with 4 other universities in gaining FDA approval for the Quantra Q-Stat and Quantra Q Plus cartridges. And through his efforts, UMC El Paso will be a participant in the upcoming TAP trial for determining the benefits of Kcentra in trauma. That's so cool.
Wow, congratulations on your work.
Thank you.
Thank you so much for
I
joining us
lost all
today.
my hair doing it.
Bradford, it's so nice to be with a friend. You're so heavily researched in perfusion and so much research in trauma. So I'm so excited to talk to you a little bit more about the bloodless care population. You know, they have a special place in our hearts, really, because it is these patients who decline or who have maybe a different way of thinking, those patients who make us think outside the box and make us come up with solutions. We learn and we grow from them, don't we?
Yes, very much so.
Yeah, definitely. And it's not always just a choice. Sometimes it's necessary too that because of a medical condition, a patient just cannot have a blood transfusion.
Yeah, I really stress that with the residents when I have opportunities to do grand rounds. We have here, and I'm not putting a plug in for Texas Tech, but
Sure.
we have about a 5-hour course that we
Hmm.
teach on transfusion, transfusion reduction, bloodless patients. And when I say bloodless, sometimes you have the religious objection, and we
Hmm.
understand that. But what are you going to do in treating a patient, as you alluded to, Marianne, if a patient comes in and has a blood type that we can't type and cross?
Yep.
Or in turn, they have a warm and a cold antibody,
Yep.
where if we give them a transfusion, we're very well going to kill them.
Mhm.
How do we treat those patients?
Hmm.
And interestingly, where we are in El Paso, there's a tribe of Indians on the other side in Mexico that come into here for treatment, and they come in here about once a month. It's fairly good size, and they all have one of these blood types that we can't really type and
Oh, no
cross.
way.
Hmm.
So because of that, we have learned to be very inventive
Hmm.
in
Mhm.
being able to treat these patients, so that they don't end up getting a transfusion. Because again, if we do, it's going to have a negative result.
Telling you, El Paso's sounding better and better every day. Sorry.
Yeah.
I'm meeting more and more patients who are choosing to decline blood products for various reasons.
Hmm.
Are you guys having the same experience?
Yes. And I've had patients come in and say, I'm willing to accept a transfusion if it comes from a person that was not infused with the COVID vaccine.
Mm-hmm.
Yep.
And, wow,
Yeah.
that's quite
We're
interesting.
seeing a lot of that across the United States.
How are we going to go about that? And the blood is not tested for that.
Mm-hmm.
Back to our original thought here is, so when a patient comes in and they tell you they decline transfusion, even if that means they may die, do you find that to be a bad decision for them personally?
No, no. And the question might come up, is it a poor decision? Where you're looking at something from the perspective of a lack of knowledge
Mm-hmm.
on the part of the patient. And the answer to that is an unequivocal no. The gold standard today in medicine is to be able to do things without transfusion. I know one of the clinical professors of surgery, if a doctor or a resident comes in and says, I had to use 2 or 3 units of red cells, the professor says, what did you do wrong?
Mm-hmm.
And I really appreciate that, because that gives me a different way of approaching it and looking at it, that the professor feels you did something wrong. What did you cut that
Mm-hmm.
you shouldn't have cut? Was the patient on a DOAC and you should have reversed that before? Was.
Mm-hmm.
And those are all questions that need to be answered. And the thing about a patient that says, I will not accept a transfusion, by and large, the surgeons and or the medical clinicians are going to be much more careful in seeing to it that the patient doesn't need it. So you get a higher standard of medicine,
Mm-hmm.
a higher standard of care. Now, some might say that's not fair. We should all be treated on the same level, and we should be very, very cautious that one person, because of a restriction, doesn't get better care than a person who doesn't have that restriction. And we're using blood as an example, where we used to have 100 units of O positive red cells on the shelf at any given time.
Mm-hmm.
COVID came in and we dropped it from 100 to 90.
Yep.
They couldn't match that. We tried to assist them in any way we could. They tried blood drives. They tried all these things. None of that worked. And we still, as the level 1 trauma center for 260 square miles, couldn't get what we needed.
Yep.
So we dropped the O positive red cells to 45.
Yes.
From 100 to
Wow.
45. But at the same time, I wrote the anemia power plan.
Mm-hmm.
And we've seen that published in the journals that have been used. I used that as a template and was able to assist our institution in implementing that. And after COVID began to decline and the blood supplier came back and said, okay, we're getting more donations, we're getting more blood. Would you like to up that number from 45 to a higher number?
Mm-hmm.
We all got together, and I was just curious what everybody else was going to say, because we had all the blood bank people there and the pathologist. We had some of the surgeons, and they all said, no, we're fine where we are. We've learned
Amazing.
to use a better standard.
Yep.
Yeah.
So I very much appreciate the fact that my institution has been willing to implement this higher level of care
Mm-hmm.
and in turn assist patients to get out of the hospital faster and in turn do better. In 1942, they came up and said that the rule should be 10-30. 10 on the hemoglobin, 30 on the crit. Well, that was written by an OBGYN. And it was accepted as gospel because it was in print. Now, I can prove to you in print that the cow jumped over the moon. Does that mean that that's correct? Well, no. But it was accepted as fact until 1997 when Polly Baer did the Canadian trick trial.
Mm-hmm.
And then they dropped the numbers to 7.
Mm-hmm.
And multiple studies went through to see if that was the case, and everybody agreed with it. So that became the standard now of 7.
Mm-hmm.
Well, during COVID, we had real problems, as I mentioned, with available red cells here. We just didn't have it.
Right.
So we dropped our numbers to 6 on the hemoglobin level.
Right.
Mm-hmm.
But if patients were in there and they were stable and they weren't having difficulties, but their hemoglobin level read as 6, we put them on the power plan and we left them alone.
Mm-hmm.
And we said, you know what? They're doing fine. Give them a lab holiday. So no more lab draws for that patient for 24 to 48 hours. And you know what? They did just fine.
Yeah.
And we had a 2.25 day reduction in ICU stay.
Mm-hmm.
We saved 1,131 units of blood over the course of this study. So we kind of proved to our own medical staff we can do this and do it better by following these guidelines than we can just relying on
Sure.
the old standard, which is using a blood transfusion. Now, with all the research that's been done, people have learned, well, I think I can do without this. I'm good enough to do it. And even my trauma surgeons have agreed with that.
Mm-hmm.
And we teach that here. We teach that here.
That was kind of my next question, is declining a blood transfusion during a trauma, is that manageable? Is that reasonable for trauma?
Yes, it is. And I can't say categorically in every sense. If
Right.
somebody has lost a limb
Mm-hmm.
in the field
Mm-hmm.
and they were not tourniqueted before the ambulance got there and they pretty much bled out,
Right.
that you're not going to be able to help them.
Right.
The problem with trauma is when you go from a hemoglobin of 14, 15 down to a hemoglobin of 3 in 10 minutes, 15 minutes, your body cannot equilibrate to that and you will not survive.
Yeah.
But patients that have had opportunity to slowly drift, your body equilibrates to that. And then you're able to adjust to this lower number. And different systems come into play. People turn very pale.
Mm-hmm.
It's unfortunate to say, but you don't need arms and legs to live.
Mm-hmm.
So where does the blood go? It goes to the source, that your brain, your heart, your liver, your kidneys, that's where it goes to keep you alive.
Mm-hmm.
But now there have been so many new drugs that have come on the market. Some of them are quite interesting, like what are called DOACs. And these are antiplatelet drugs. And they're called rivaroxaban and apixaban. That's their sales, that's their market name. What they sell them under is Eliquis, Pradaxa, Xarelto. What those drugs do is they want to inhibit a percentage of the platelets so you don't clot up in certain areas. And that's a good thing to do. But the problem is, for purposes of explanation, is these drugs, for lack of a better word, take your platelets that run around your body like a closed fist. And then when they need to be activated, they open, they get sticky, and they adhere to the hole. And then you form a clot. That's the way the good Lord made it. But now, with these drugs, what they do is they take the platelet and they put tape all around it. So when it wants to open, it can't. Well, finally, they came out with a reversal agent, and that's called Andexa.
Mm-hmm.
And what Andexa does is it takes the tape off the platelets so it can work. It doesn't kill it. It just takes the tape off. And it does it in 2 minutes. It's a miracle drug. It's a one-trick pony, but it's a miracle drug. When a person comes in on a DOAC and they're bleeding, and you reverse that, you're able then to get much more hemostasis. There's new drugs that have come along that have been very, very good. We're using something, I sent Sarah a slide on a product called Blood Stop.
Oh, yeah.
This is a relatively new formulation. And when you put it onto the area that's bleeding, whether it be the liver, the kidneys, the spleen, whatever, it hits there, it becomes translucent, and in a short period of time, it melts and it stops bleeding. We've had about a 55% reduction in bleeding with the use of this product.
Wow.
So if I were to say to, because I brought it in, and if I were to say to the trauma surgeons now, we're going to go back to the old way of doing it, and I'm going to discontinue blood stop. You'd see me hanging from the yard arm out there. Because it works that well.
Yeah.
And it's very assistive in being able to control bleeding. There are on the horizon, and I'm not speaking generations from now, but close on the horizon, new blood substitutes that are coming out. And these are being endorsed by the Pentagon.
Wow.
Okay.
So you don't wait for a patient who is losing blood to put him on the power plan when he bottoms out.
Mm-hmm.
If it gets to 3, which you can survive from if your heart is not full of clots and everything else, and then slowly you'll come out of that hole. But if you can start the person at a hemoglobin of 8, 7, get hemostasis, get them on the power plan, they might drop, but they're going to try and come right back up again. And I've proven that here multiple times.
Yeah.
The use of IV iron is extremely important. And then Procrit, epigen, migrates into the bone marrow and in turn tells the body what to make. Epigen, EPO, erythrocytes make red cells, and that's what it does. It stimulates them. We have platelet thrombopoietics that make platelet formulations now for the body. So we have all these things that we can use. We can use Neulasta to make white cells.
Right.
So they've learned, science has learned how to target this. So if you can get the bleeding stopped, a patient in trauma will do fine, as long as you put them on the power plan, and they'll do well.
In trauma patients, we're hearing a lot about whole blood. Whole
Yes.
blood is hot now, right? And is that so? In a trauma patient that comes in with, their arm or their leg cut off, like we talked about earlier, is it better to just give one type of product, one specific type, or is whole blood better?
Using whole blood, and this has all come out of the military with respects to the investigations that were begun by Spinella in 2009, dealing with whole blood from injured soldiers. And what they found was if they use whole blood in that perspective, their survival ratios increase 4 times. And in turn, because you're using one product that contains red cells, platelets, white cells, plasma, all of the specifics, if you're able to use that, you're going to use 60% less blood.
Okay.
So for a patient that says, I'm willing to accept a transfusion, you're going to have a much better effect with the use of whole blood than you would with components.
Okay.
The average platelet count in whole blood is 150,000 or more. 150,000 or more.
Okay.
When you look at AABB, and in turn their circular, which is their Bible, they will tell you, and I gave Sarah a slide for this, that the average platelet count of platelets from the blood bank to a patient is going to rise the platelet count between 25 and 35,000.
Okay.
Whole blood, 150,000.
Wow.
Yeah.
So that's why you're going to get much better hemostasis with whole blood. And if you use something that works very well, you don't need as much.
Yeah.
That's the 60% reduction.
I think one hitch with the whole blood, it's only for emergent use, right? Like a tiger bite or something like that. It can't be like, you can't, if you're suspecting bleeding or there's oozing, it's got to be emergency, right?
Right. We use whole blood in the trauma scenario, as you've mentioned. But there are times where we can't.
Right.
And when we cannot use it, we approach it as best as we can through other means. And so far, we've been successful.
Can you explain why a unit of whole blood would raise a patient's platelet count more than a unit of platelets alone?
Yes. Okay, great, good question. Whole blood is taken from one person.
Mm-hmm.
It is not separated and tested. We don't take it apart and then put it
Right.
back together again.
Right.
It's one unit of whole blood from one person. It's always O positive. Well, I shouldn't say always. 99% of the time, it's O positive. And in turn, that blood then is refrigerated. It's only got 70 ml of anticoagulant in 500 ml.
Okay.
Very low in the anticoagulant.
Okay.
Where if you look at red cells, about 220, 230 ml, 100 to 110 ml, almost half is anticoagulant. Now, the
Okay.
platelets have to be separated from whole blood. So
Mm-hmm.
they separate out the red cells, they separate the plasma, they pull out the platelets.
Mm-hmm.
When they do that, those machines, even as good as they are, they beat the heck out of the blood.
Okay.
Thus, the platelet count drops because the platelets have been abused,
Okay.
for lack
Great
of a better
questions
word.
there.
They're damaged.
Yeah.
Yeah.
Yes.
And they spend some more time probably in refrigeration, right? Which also lends to more breakdown.
There are studies now and where they're looking at cold storage platelets
Mm-hmm.
as to
Okay.
be a benefit. But
Okay.
most platelets are kept at room temperature.
Oh,
And that's
okay.
why we go into the blood bank, you'll see that rocker,
Mm-hmm.
and they'll be agitating
Yes.
the platelets.
Okay.
And they're kept, as I said, at room temperature. So you can only keep platelets really because 7 days is the time frame.
Mm-hmm.
But when they draw them from the patient, then they have to separate out. And sometimes they have special machines now that will just separate platelets.
Mm-hmm.
But then they have to test it. They got to put it into a bag and they got to do all the important necessities. And by the time they're shipped to a hospital, they have 5 days.
Mm-hmm.
Now, for every day that they sit on the rocker, the lower the platelet count goes, which is understood. Milk is the same way.
Right.
When you go to
Mm-hmm.
buy
Yeah.
milk, you don't look at the one that's going to go out of date tomorrow. You
Right.
look for the freshest one.
Right.
And for lack of a better word, you can keep them for 5 days. On day 5, the platelets begin to grow fur. So
Okay.
when you give that to a patient, yuck.
Mm-hmm.
Right.
So it's better to try to prevent that if at all possible. Yeah, whole blood is the new kid on the block. There's lots of studies going on about this right now. And looking at this, we got invited, we did a clinical study because I was asking in whole blood, how long do the platelets last? Because again, if you separate platelets, they can last for 7 days. Platelets replace themselves in the body every 7 days. We know that.
Mm.
When you take blood and you refrigerate it, how long do the platelets stay alive and are beneficial? Well, we did that study over 3 weeks. We had multiple volunteers and we gave them a gift card for coffee and things like that to come in and donate their blood. They couldn't have taken aspirin for a week.
Mm-hmm.
They couldn't be pregnant if they were females that tested, and a couple other parameters. But, so we would have good, clean blood.
Right.
We studied that, and what we found out was platelets were good for about 9 days in refrigeration. After that, you began to see this much of a curve on the downward aspect. So we ran that on 2 devices. We ran that on Rotem and we ran that on Quantra.
Mm-hmm.
And then we presented that to each company so they would have that data. And Quantra submitted that to Thor,
Mm-hmm.
which is Trauma, Hemostasis, Oxygenation Research. That is an invitation-only group. And with our research, I'm very proud to say we got invited.
Oh,
So
congratulations.
yeah, boy, we all kind of did backflips when we got that invitation. So that was pretty exciting that we'd be able to see opportunities to advance the aspects on transfusion management, transfusion free, blood management, all of that fits into the same category there.
And so, if you had to summarize the benefits of whole blood in bullet points, what would your bullet points be?
Faster resuscitation, quicker aspects associated with hemostasis because of higher platelet counts, more of everything in there. Reduced utilization, because the last thing you want to do is give a person a lot of blood, because the more blood they get, the less the survival becomes. So less in that perspective is definitely more.
Yeah.
So whole blood has aspects from a research perspective that is opening paradigms for all kinds of other research. New drugs are going to come out of this. New products are going to come to be able to assist us with blood substitutes and all of the things to be able to help us work with this, because research has gotten so much better in the last decade. And the FDA is really encouraging this. So we're finding some interesting parameters based on that.
I was on a call today where I was pleased to hear that many institutions are starting their MTP with whole blood.
Yes,
Very
that's
nice.
That
true.
was really interesting. Yeah.
Yeah. Yeah. It's not necessarily needed for everyone. And for patients that cannot, because of a type and cross issue, a warm and a cold antibody, or refusal of transfusion,
Sure.
that doesn't indicate or that doesn't mean they will not survive. It's another treatment algorithm that might be removed, but then you're going to have to use another one.
Yeah.
Sure.
And that's the one benefit of medicine. If you went into your doctor and your doctor said, I want to give you penicillin, and you said, I'm allergic to penicillin.
Right.
Does he walk away? No, he puts you on a myosin, and you go from there.
Right.
So there's lots of different options that we're finding very, very useful today.
Yeah. And yeah, that's how patient blood management, or managing the patient's own blood,
Yes.
was born, right?
Yes. Very true.
Treatment options for those patients. So when a physician offers a patient a blood transfusion, what things should the patient consider before they decide to accept or decline? Because you can decline and accept later. How does a patient make that decision that now is the time or not?
That's a very interesting question. That's a loaded question, too. But when you analyze that from the perspective, I don't know any patient, the old curmudgeon down the street to the kindest, sweetest person that you'd ever want to meet, that would ever go into a hospital and say, I need this surgery. Make sure I get a blood transfusion. No one would do that. But if a surgeon were to tell you, I can't do this surgery without blood, to me, that's telling you something. Should I seek someone else that has a little more experience in this perspective? Can we do bloodless surgery? Absolutely. Don't let anybody tell you we can't. We can.
I think that's a really good point for patients to know that, sometimes somebody will go in and they'll fight and say, oh, you could do this without blood. But maybe you need to think about going to somewhere else that those people are comfortable and competent in performing a surgery without blood. And, maybe just help the physician realize that they really should be doing better and get comfortable with not using blood when it's not needed. In these surgeries like API, or I've, other hospitals I see, they'll turn you down for an API if you don't sign the blood consent, which is insanity to me, or an elective knee or hip. Like, it's just, there's a hospital up the street that will not do unless you sign that blood consent. And Patients should understand that they should go to someone else who is comfortable in performing surgeries without blood and have the tools and the skill set to perform that surgery. They'll be better off.
Mm-hmm.
Yeah, and you have the right to your request. We have a logo here, a mantra that we're here to teach, to heal, educate, so we don't turn down anybody.
Mm-hmm.
And we do that for a number of reasons. Residents need to be exposed to as much as possible.
Mm-hmm.
But number two, if you're going to have a program like this, you better make sure you have the tools to do it. And you better make sure you supply the education so people know what this tool is and how to use it. And if that's the case, bada bing, bada boom, you can do most procedures without it. Blood is expensive.
Mm-hmm.
And every time you give a red cell transfusion, you increase the risk of infection.
Mm-hmm.
Here's an interesting statement with respects to uh, pharmaceuticals versus biologic. Blood is a biologic.
Mm-hmm.
You really can't sue blood banks for what they do. It's unless they've intentionally done some things, and Canada proved that,
Mm-hmm.
where they imprisoned several people that were giving people blood that had HIV in it. So it's very difficult to do that. But you can sue a pharmaceutical.
Mm-hmm.
So the pharmaceutical companies are going to make sure if they tell you our product has this much fibrinogen in it, guess what? It's got that much in it because they don't want to be liable.
Thank you so much for your hard work in the patient blood management realm
Yes.
and in trauma work and research. If we think about today's conversation, it's been very enlightening. What do you think is the main takeaways you would like the audience to take away from our conversation with you today?
If a surgeon tells you, I can't do this without blood, I don't want to be cavalier, but he might be telling you, this is my skill limit.
Mm-hmm.
There's nothing wrong with saying to that surgeon, thank you. I appreciate this. Thank you for the consult. Goodbye. And there are other surgeons that you can look to and to be able to find results that will meet the necessity of what you're doing. Hospitals are really endorsing the use of doing things without blood because we have to look at it and appreciate hospitals are businesses.
Mm-hmm.
And if you are spending too much money utilizing this product, the CFO is going to talk to you. So if you're able to do more with less, and the World Health Organization is even supporting that now, if we're able to do more with less, we're always going to have a job. And in turn, our patients are going to be much happier because doctors show their approval or their dissatisfaction with their feet. If they don't like it here,
Yep.
they'll go here. If this hospital is going to provide what this hospital won't, guess what? They're going to go over there. And especially if a doctor has a real interest in using less, he's going to have all the business he can handle. It's not to say that he'll never have to use blood, but by and large, he'll reduce that exceptionally. And in turn, have better outcomes, better referral patterns, happier patients, less time in the hospital, and in turn, better outcomes all the way around.
Thank you
That's
so much
all
for
I gotta
joining us
say.
today.
Oh, it's been a pleasure. I've learned so much from you today. Thank you so much.
Well, I appreciate the opportunity. Thank you very much.
We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
Special thanks to our guest and our producer, Delaney Coronado, and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward, and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.